In this video, we will be discussing about smoking related ILDs. We should understand that there are many interstitial lung diseases, many entities under ILD which are related to smoking. But under this heading of ILD, we basically discuss or we study only two ILDs. One is respiratory bronchiolitis associated ILD and second is desquamative interstitial pneumonia. These are exclusively studied as associated with smoking, although other entities like interstitial pulmonary fibrosis or IPF and many other diseases are also associated with smoking, but we study only these two under the heading of smoking related ILDs, right? These are the full forms. Okay, these interstitial abnormalities are often found incidentally on routine chest X-ray and HRCT in elderly smokers above 50 years of age. Age group is very important, above 50 years, and they are heavy smokers. Elderly people, heavy smokers. Right. See, it is very important to understand that respiratory bronchiolitis associated ILD and DIP, they both are very slow and insidious diseases. These are not very aggressive or very acute kind of diseases. So people do not present with signs and symptoms of these diseases early in the course. Obviously, when the disease gets decompensated, then the patient presents. So most of the times they are found incidentally, right? What are the clinical features? The clinical features are same as that of other ILDs. First of all is dyspnea. Second is dry non-productive cough. And in this diseases we will be able to infer that there is wheeze associated with inspiratory part of the respiration. Then there is clubbing. Clubbing is seen in some cases. Age group most commonly involved is 50 to 60 years of elderly heavy smokers, chronic heavy smokers. These smoking related ILDs, they account for less than 10% of all idiopathic interstitial pneumonias, right? What you will see in HRCT, see the features of these two entities are almost similar. On HRCT we will see bronchial wall thickening, ground glass opacities, right? That is seen in most ILDs. Third is reticular pattern. Again, this is seen in most ILDs. So here what is important is bronchial wall thickness. This is more important, bronchial wall thickening. There is a characteristic feature of DIP, that is bilaterally symmetric ground glass opacities, and they are very much prominent in DIP, more prominent. What? Bilaterally symmetric ground glass opacities. What are the histopathological findings? See, we have to differentiate between RB-ILD and DIP, and this is done on the basis of histopathology. What you will see on HPE in respiratory bronchiolitis, you will see that there is accumulation of pigmented macrophages, right? Where? In the respiratory bronchioles and in the alveolar ducts. There is chronic inflammation of the bronchiolar walls which causes alveolar fibrosis, right? And this will cause distortion of the pulmonary architecture, chronic inflammation and fibrosis, alveolar fibrosis. But it is very important to note that the involvement in RB-ILD is patchy. It is confined to peribronchial regions, whereas in DIP we will study that it is diffuse, right? The findings are almost similar, but in DIP they are diffuse, and in RB-ILD they are patchy, right? Let us see the HPE findings on DIP. Again, respiratory bronchioles and alveolar ducts are involved, and there is accumulation of pigmented macrophages. It is very important to understand and remember that there is accumulation of pigmented macrophages, and pneumocyte hyperplasia is also seen. Again, there is chronic inflammation and alveolar fibrosis. Chronic inflammation, alveolar fibrosis, which will cause distortion of lung architecture. And remember, the findings are diffuse in this case. If we compare, only difference is that here it is patchy, here it is diffuse. Again, pigmented macrophages, chronic inflammation and fibrosis leading to distortion, right? Now, what is the treatment part? See, most of the symptoms will be gone if you are able to quit smoking. As far as pharmacotherapy is concerned, glucocorticoids are the first choice, and if they fail, we can give cytotoxic agents like cyclophosphamide and azathioprine. Along with them, for symptomatic benefit, we will give bronchodilators. All these things will suffice for the treatment. They will slow down the progress, right? Although the disease is already very slow, they will further improve the symptoms and slow down the disease, right? And death secondary to smoking related ILDs are rare. Deaths are very, very rare. Means prognosis is very good, even with treatment or without treatment. But we have to give treatment to slow down the disease and alleviate the symptoms. That is all about smoking related ILDs. Let's have a recap. Two entities are studied, RB-ILD and DIP, found incidentally elderly smokers 50 years of age. Clinical features are again 4 we have to remember: dyspnea, dry cough, wheeze and clubbing. Age group 50 to 60 years, heavy smokers. These two entities account for less than 10% of idiopathic interstitial pneumonias. HRCT, again the symptoms are same in RB-ILD and DIP. Only difference is that in RB-ILD the findings are patchy, and in DIP the findings are diffuse. In DIP the findings are diffuse, right? HRCT findings: bronchial wall thickening, ground glass opacities, reticular pattern. In DIP the bilateral symmetric ground glass opacities are seen. These are more prominent. Histopathology is the main investigation, investigation which is used to differentiate between RB-ILD and DIP. In RB-ILD it is patchy involvement, in DIP it is diffuse involvement. Treatment: smoking cessation, glucocorticoids. If they fail, we give cyclophosphamide, azathioprine. Along with them, we give bronchodilators. Prognosis is good. That's all. Thank you.